I am Dr. Mohammed Shakil Ansari, convener of today's program. I have with me my colleagues, Dr. Firdaus Ahmad Nazar as speaker, Dr. Nazreen Fatima as organizing secretary, and Professor Sayyid Shah Alam Sahab as chairman organizing committee of this fourth national webinar. We are organizing this webinar under the patronage of our director, Professor Abdul Wadud sir. Today's webinar is also a part of celebration of Azadi Ka Amrit Mahotsav. I want to intimate all of you that today's program will cover two different topics. The first topic to be covered in detail is burn and its management by our teacher, Professor Tafsir Ali Sahar, ex-chairman Department of Jarahat, AKTC AMU Aligarh. And the second topic to be covered is fishery nano treatment updates. Where do we stand in 2022 by our colleague, Dr. Firdaus Ahmad Nazar, Assistant Professor, Department of Ilmul Jarahat, NIUM Bangalore. Our program will schedule as, first of all, there will be a welcome address by HOD Ilmul Jarahat, NIUM Bangalore, Professor Sayyid Shah Alam sir, followed by a speech by our beloved director, NIUM Professor Abdul Wadud sir, followed by two lectures by our respective speakers. After each lecture, enough time will be given for discussion with the speakers. So all the participants are requested to keep their audios muted. The program will end with a vote of thanks by Dr. Nazreen Fatima, Assistant Professor, Department of Jarahat, NIUM Bangalore. Therefore, it is time. Now I invite HOD Ilmul Jarahat, NIUM Bangalore, Professor Sayyid Shah Alam Sahab for a welcome address. Professor Sayyid Shah Alam Sahab, please.
Thank you, Dr. Shakil sir. Assalamu alaikum warahmatullahi wabarakatuh. Good morning to one and all. I am thoroughly pleased to witness you all here. It is a moment of extreme pleasure to welcome the guests who are present here to attend this one-day national webinar as a part of celebrations of Azadi Ka Amrit Mahotsav. On behalf of the organizing committee, I welcome to all the participants who have joined today's one-day national webinar on Ilmul Jarahat Updates 2022. Particularly our beloved director, energetic director, Professor Abdul Wadud sir, for managing time out of his busy schedule. Welcome you, Director sir. I bid a very warm welcome to today's speakers and my teacher, especially Professor Tafsir Ali sir, ex-medical superintendent of AKTC AMU, ex-chairman, Department of Ilmul Jarahat, and Dr. Firdaus Ahmad Nazar Sahab, Assistant Professor, Department of Ilmul Jarahat, NIUM Bangalore. I welcome to all our teachers, faculties, colleagues, and students who joined us. We all have gathered here today to attend this one-day national webinar based on enhance our knowledge. This series of webinars intend to resolve the practical hurdles faced by doctors and practitioners. Today's webinar will cover two important topics on burn and its management, and followed by fishery anno treatment updates. Where do we stand in 2022? Both the topics are of great importance and very common topic. This webinar will throw light on different aspects of bird and fishery anno. Therefore, I am sure this webinar will be meaningful and thought-providing and useful to all the participants. I once again welcome one and all who are with us. Without any further delay, I would like to start the event. We would be delighted to have your suggestions and questions at the end of the event. Thank you again, one and all. Thank you.
Thank you, HOD sir, Professor Sayyid Shah Alam sir, for your welcome address. On behalf of the Department of Ilmul Jarahat, I am thankful to Director NIUM, Professor Abdul Wadud sir, to give a few valuable minutes out of his busy schedule, and also to provide this platform for organizing the fourth national webinar on Ilmul Jarahat updates. Now I request our Director NIUM, Professor Abdul Wadud sir, for his sweet and encouraging speech. Director sir, please.
Thank you, Dr. Shakil. Am I audible?
Yes, sir.
Okay. So, Assalamu alaikum. A very good morning to all of you. Respected Dr. Tafsir Ali, Professor, Department of Jarahat, Ajmal Khan Tibbiya College, AMU Aligarh, Professor Sayyid Shah Alam, Chairman Department of Jarahat, National Institute of Unani Medicine, Dr. Shakil Ahmed, Dr. Mejabin Fatima, Dr. Firdaus Ahmed, and students of the Department of Jarahat and all participants. Once again, a very good morning to all of you. National Institute of Unani Medicine, Bangalore, established for Unani education, research, and patient, is marching towards achieving the goals set for it. The institute routinely organizes conferences, seminars, workshops, training programs, and now a series of webinars. On the occasion of Azadi Ka Amrit Mahotsav, all the departments of this institute have been given the task to organize at least 2 webinars. It is the probably it is the 3rd or 4th webinar organized by Department of Jarahat, National Institute of Unani Medicine, Bangalore, and I think that is the highest number of webinars organized by this department. Department of Jarahat, though started late in the institute, has become fastest growing department of the institute. This department has special relevance on many accounts. For example, the staff and the students are hardworking, and they also work beyond the duties whenever it is needed. It has become the fastest developing department of the institute. It contributes a lot to OPD and IPD. It provides a good combination of modern and classical surgical management to the patients. The topic selected for today's webinar is relevant. Both the topics are of practical relevance. I hope this webinar will enlighten the participants and convey the message of updates of surgical management to the students and to the researchers and to the teachers who are engaged in Jarahat in various Unani colleges of India. Once again, I congratulate for organizing the highest number of webinars in this institute to the Department of Surgery. Thank you. Assalamu alaikum. तफसीर भाई अस्सलाम
जी तफसीर साहब आपका ऑडियो म्यूट हो गया सर। तफसीर सर आपका ऑडियो म्यूट हो गया है, प्लीज ऑडियो स्टार्ट करें। कौन कर
तफसीर भाई अनम्यूट कीजिए।
अस्सलाम वालेकुम।
कैसे हैं?
वालेकुम अस्सलाम
जी कैसे हैं?
अल्लाह का शुक्र है
जी।
Thank you very much, Director sir. Thank you very much for your appreciating and encouraging speech. I, on behalf of the Department of Ilmul Jarahat, sir, assure you that in the future also we will come up with your advice and expectations. Okay, sir. Thank you very much, sir. Now we proceed further towards today's webinar lecture. The first topic to be covered in detail today's webinar is burn and its management. As we know that burn is an injury to the skin or other tissues caused by heat, cold, chemical friction, or ultraviolet radiation. Burn is classified into superficial or first-degree burn, partial thickness or second-degree burn, full thickness or third-degree burn, or fourth-degree burn, according to the involvement of tissues and depth of the burn. And treatment of the burn depends on the severity of the burn. As we know, most deaths occur due to the burn in the developing world only, particularly in Southeast Asia. But due to the availability of well-developed health facilities and infrastructure in the United States of America, approximately 96% of those admitted due to burn centers survive their injuries. Today, we have a distinguished speaker for the detailed deliberation on burn and its management, Professor Tafsir Ali Sir, ex-chairman Department of Jarahat, AKP. I want to introduce all of you, today's speaker and my teacher, Professor Tafsir Ali Sir, to all the participants. Professor Tafsir Ali Sir completed his BUMS and MS Jarahat from AKP Aligarh and he also completed MBA Healthcare Services as well as MSc in Clinical Research and Regulatory Affairs and PG Diploma in Preventive and Promotive Healthcare. He has attended 22 training programs and workshops, etc. He has visited abroad so many times, especially China, Turkey, Iran, Sri Lanka, and UAE, especially for the purpose of research and academic activities. He has published 3 books, 12 research papers, and he has supervised 10 theses also. He was Deputy Medical Superintendent, AK Sidya College Hospital for more than 10 years. He has in charge hospital management in 4 AKCC hospitals. He was member in charge Dawakhana Sidya College, AMU Aligarh. He was chairperson or chairman of the Department of Jarahat from 2014 to 2017. He was a warden also, SS Hall South, RM Hall, NM Hall for more than 8 years. He was honorary project coordinator, SISPSA, for more than 18 months. He was assistant to prenatal examination, Faculty of Family Medicine for 1 year. He has received 3 awards and 1 gold medal also. Awards are Dr. Panna Lal Memorial National Award, Integrated Medicine for the year 2016 by NIUM. Distinguished Scientist International Award 2016 by Veera, Chennai, India. 3rd award by Dr. Zakir Hussain Foundation Pentagon Excellence Award 2017 in the field of healthcare services. He has received 1 gold medal by Indian Society of Alternative Medicine, Kolkata. He has attended so many workshops, seminars, conferences, symposiums. As a delegate, I think 50 seminars and conferences. As a speaker and paper presenter, more than 31 seminars. As a chairperson, more than 18 workshops and conferences, etc. Now I request my respected teacher, Professor Taqir Ali sir, ex-chairman Department of Jarahat AKTC NIUM Aligarh, for his lecture on burn and its management. Please sir, start your lecture now.
Yes, sir. Please, sir.
Should I continue?
Yes, sir, you can continue, sir.
My voice is audible.
Yes, sir.
Yes, sir. Please.
Bismillahirrahmanirrahim. First of all, I would like to thank the organizers of this online seminar symposium, especially Professor Abdul Wadud Sahab, Professor Sayyid Shah Alam Sahab, Head of the Department of Jarahat, Dr. Shakil Ansari, Dr. Mehjabi, Dr. Firdaus, and all other senior teachers and the participants. The topic of burn and its management is a very vast and very important topic. Since there are many types and many causes of burn, and every cause and every type of burn need a specific treatment, it is really very difficult to include and to conclude all the aspects in a single lecture. It is so important and so large topic. In this small lecture, only one aspect, only one cause, one small component of the burn will be tried to cover. I know it will not be covered even in this lecture. And that is the cause of burn because of thermal injury, because of heat injury. In this small introduction, you can see that it is the most common among the severe injuries, from starting the home up to the workplace. There are so many chances of getting injured with the causative agents causing burn. This demography, this figure has been taken from WHO. An estimated 1,80,000 deaths occur every year, mostly from poor countries. The severity of this can be imagined. This is the overall demography, including the countries which are rich and having resources, and those who are poor countries and developing countries. In India, exact figure cannot be calculated because not all cases approach the hospital, not all cases come into the record. But still, it is true that high incidence of burn injury occurs in India. WHO figure is an estimated figure, not exact figure, because this figure has also been taken from the hospital records. This figure has also been taken from WHO. And now come to the main topic. What is the definition of burn? Very simple, that coagulative necrosis because of the injury caused by the heat, radiation, radioactivity, electricity, and even friction or contact with chemicals. Both strong acids and strong alkali comes into this category. Concentrated acids and concentrated alkaline liquids. As I already spoke, that all the topics, all the aspects of the burn cannot be covered in this small lecture. Therefore, I have taken only one causative agent, only one aspect, that is thermal burn. Maybe because of the injury from hot liquids, hot solids, directly coming into contact with flame. What is the diagnostic criteria? Diagnostic criteria is based on the history and physical examination to evaluate the burn wound. What is the depth? What is the extent of the burn? Because on the basis of the diagnosis, the treatment starts. History, time of burn. The longer will be the duration of the contact with the hot object, the more will be the damage. The burn may be because of some revenge, some medico-legal aspect. Another one is ample history, ample allergy, medications, past medical history, last meal, events, and environment of burn injury. To know the extent of burn and depth of burn or degree of burn, it is important to evaluate the depth and the surface area. According to the depth of burn, it may be first degree, which affects surface area of the skin, epithelial damage. This is clinically insignificant. Starting from redness, minor inflammation, swelling, pain, dry peeling skin. This needs no specific treatment, just some soothing agents, even application of aloe vera gel may be enough, some anesthetic agent. Second degree burn, which is partial thickness burn, which is very painful condition because of the involvement of the nerve. And third degree burn, that is full thickness burn, the whole of the epidermis, dermis is damaged, that is third degree burn. This is according to the depth of the burn. From management point of view, overall assessment is necessary, not only the depth, but also the extent of burn. For example, it may be that it is second degree burn, but more than 40 degree, more than 40% of the total body surface area. It may be third degree burn, but not more than 20% of the total body surface area. Both are the serious conditions. While treating or considering the patient for treatment, it is necessary to consider both depth of burn and the surface area of burn. For calculation of the surface area of burn, in case of adults, there is Wallace rule of 9, well known and well applicable rule. Another is a rough idea with the palm. Size of the palm equals to 1% of total body surface area. Both are important. Some area, rule of 9 is as a whole, including the limb and trunk, perineal area, neck, head. But for the calculation of a smaller area, the palm method is also important. As I already told that first degree burn are very easily manageable, need no specific treatment. Here, the partial thickness or second degree or third degree burn will be considered for the management purpose of view. First of all, it should be decided that whether the patient is in need of hospitalization or can be treated at home or from clinic on OPD basis. Partial thickness burn more than 25% of total body surface area in adults need hospitalization. They cannot be treated in clinics or at home. If the age of the person is above 50 years of age or the child is below 10 years of age, more than 20% burn, more than 20% of total body surface area burn need hospitalization. All burns of face, eyes, ears, and perineum, they are the sites of concern. They also need hospitalization. Further, I have included this line about chemical burn, electrical burn, because in this slide I am discussing about the need of hospitalization. Chemical burns, electric burn, inhalational injury, and underlying debilitating diseases, the patient needs hospitalization. In management, once the patient is hospitalized, I'm talking about the second degree and third degree burn. First of all, the most importantly is the examination of airway. Airway burns inhalational injury may cause airway burns. There may be smoke inhalation syndrome. There may be severe burn on face and neck. There may be edema, laryngeal edema. And in such cases, there may be need of intubation, or in specific cases, in more complicated cases, tracheostomy may also be required. From starting the examination of airway up to the maintenance of proper airway for oxygenation is necessary. Oxygenation at the rate of 8 to 12 liter per minute in cases of dyspnea, major burn, airway burn, where the patient has inhaled smoke is necessary. Another aspect of the admitted case is fluid resuscitation as per the standard formula. Standard formula, Parkland's formula may be adopted. In first 24 hours, the fluid calculated as per the Parkland's formula is to be infused, and in next 24 hours, half of the fluid that has been infused in first 24 hours is to be given. This is also to be remembered that whatever fluid has been calculated in for first 24 hours, 50% of the fluid is to be transfused in first 8 hours, and rest 50% in next remaining 16 hours. Another is catheterization. As a standard formula, all the cases having burn which is more than 20% of the total body surface area need catheterization. For pain relief, starting from morphine, analgesic drugs, pethidine, like pethidine can also be given. And these drugs better to introduce in through IV route. Since the patient is kept nil orally at least for first 3 days, that may be extended as per the need. Nasogastric tube insertion is necessary to decompress and to evacuate the gastric secretions. It also helps in starting early feeds. Some patients, even after 3 days, may not be able to take oral food by themselves. In such severe cases, nasogastric tube will also help in starting early feeds. Antibiotics are to be given. Broad spectrum antibiotics. H2 receptor antagonist. Burn may cause some gastric complications, including gastric erosions and gastric ulcers. That is curling ulcer. That is one of the complications of burn. I will discuss in the slide of the complications. In such, to avoid such complications or to minimize the chances of such complications, H2 receptor antagonists have role and need to be introduced. This may also reduce the chances of gastrointestinal hemorrhage indirectly. This will also reduce the chance of acute stress ulceration. H2 receptor antagonists are so important. Another one is tetanus prophylaxis. This is also important. A large area has exposed to the external environment. The tetanus organisms are almost everywhere in the air, in the soil, in the clothes we are using. We should use tetanus prophylaxis, both active and passive, both the ways. Patient should be isolated. Isolation of the patient is also important. It will not only give relief to the already in pain patient, but also reduce the chances of infection at the site of wound. Patient isolation is necessary at cool and calm and sterile place. Isolation is important. The most important part now comes, that is burn wound care. Burn wound care may be through open method or maybe through closed method or through dressings. Both may be adopted according to the need and site of burn. That decision is to be taken on the spot. But some common criteria for the wound care should be adopted. That is, all sterile precautions are needed to be taken while dressing the burn wound. The burn wound may be cleaned with the sterile water. Simple, but sterile water may not be present everywhere in hospitals. Most easy is dilute Savlon, normal saline, maybe Ringer's lactate. The fluid may be like these. But the basic thing is that it should be cleaned with sterile liquid. Debridement is also necessary. You have to remove the blisters, non-viable tissues. Debris is to be removed, dead material, debris, burn material, which is not supporting the body but causing toxicity and giving chances for infection. That is to be removed. Debridement is important. Gentle debridement. For application, topical application, the commonly used topical antibacterial agent is silver sulfadizine, soframycin ointment. Today are already prepared. Dressings are also available that should be placed over the burnt area in case we are giving closed dressing. Wound can be managed by, I already told, can be managed by exposure or closed method. Sclerotomy may be required when there is severe burn, jal ke sukad gaya. In that cases, it is necessary. And now come to the nutrition. Nutrition on an average may be allowed from third day. This may be the duration of starting oral may be prolonged, but this is the overall duration. That oral may be allowed from third day. And oral fluids may include protein and vitamins in calculated dosage. In adults, 25 kilocalorie per kilogram of the body weight. In case of 40% of burn, more than 40%. Children 60 kilocalorie requires more energetic food. And in case of protein, in adults 1 gram per kilogram body weight, and in children 3 gram per kilogram body weight. And vitamins should also be included, especially vitamin C, vitamin A, vitamin E, which helps in the early epithelialization and also promote healing. Other supportive therapy includes physiotherapy of the joints, compression dressing. Compression dressing is actually done to prevent hypertrophic scar. Also, it helps losing the fluid into the third space. The major problem in next slides under the heading of the complications. One is the burn shock in acute complications, burn shock. The loss of fluid into the third space and loss of fluid into the atmosphere from the raw area. This compression dressing can minimize the chances of, not in all cases, wherever it may be applicable, compression dressing may reduce the chances of losing the fluid into the third space. Another one is psychotherapy. This is the big trauma. Later on, the patient may need psychotherapy to come out of the consequences of that trauma. In cases, because work is not so easy, particularly third degree, second degree burn, there may be contractures, there may be other complications, there may be burn injury on the joints, there may be inhalational injury leading to the burn of the trachea, windpipe, leading to the fibrosis and narrowing of the passage. In such cases, specific rehabilitation, specific physiotherapy may be required. These are the complications. Early complications include burn shock, renal failure, smoke inhalation syndrome, septicemia. These are early complications. and late complications include hypertrophic scar, keloid contractures, protein loss, Curling's ulcer, Marjolin's ulcer. Yeah, last one is the malignant condition. It takes time to develop. Investigations include hemogram, coagulation profile, blood grouping, random blood sugar, kidney function test, urine, XHS, serum electrolytes, and LFT. First aid I have included in the last because the participants of this program, this is not so important for the participants. Now come to the Unani drugs. This is the most important part I have tried to include. इसमें आस, उसका जो कॉमन नेम और बॉटनिकल नेम है वो मैंने दिया हुआ है। आस जो है, जितने भी क्रॉनिक अल्सर्स हैं या क्रॉनिक वुंड्स हैं, जाहिर है एज ए बर्न देयर में भी चांसेस अल्सर लाइक कंडीशन, अर्ली granulation tissue, आस, particularly when आस is mixed with the रोगन-ए-ज़ैतून। रोगन-ए-ज़ैतून ये ब्लिस्टर्स के ट्रीटमेंट के लिए और जो क्रॉनिक अल्सर है या लार्ज बर्न एरिया है उसके ऊपर अप्लाई किया जाता है। यहाँ एक चीज बता दें कि जितनी भी चीजें हैं ये लोकल केयर के लिए हो सकती हैं। कितनी इफेक्टिव हैं, उनके कोई कॉम्प्लिकेशंस तो नहीं है। दिस इज द टॉपिक ऑफ रिसर्च। सारे एस्टेब्लिशमेंट के साथ जो है इसको रिसर्च करके इनके रिजल्ट्स को जो है वो सामने लाया जाए। ये सिर्फ एक कलेक्शन है, कुछ चीजें इसमें, many of these are being used in minor or moderate burns as a local topical agent। यहाँ पे एक चीज इसमें यूनानी ड्रग्स में इंक्लूड करना चाहूंगा, उसमें रह गई है वो, खास तौर से जो कट्स हो जाते हैं उनमें ब्लीडिंग को रोकने के लिए हम लोग फिटकरी का इस्तेमाल करते हैं। फिटकरी, अच्छा हल्दी का भी इस्तेमाल करते हैं, फिटकरी और हल्दी। एक चीज तो ये कि टॉपिकल बर्न वुंड के अंदर टॉपिकल हल्दी का इस्तेमाल जो है वो ठीक नहीं। सिस्टमिक यानी हल्दी जो भी वॉटेवर वाटर से या दूध के साथ प्रोटीन भी मिल जाएगी, न्यूट्रिशन के बारे में अभी बात हुई, तो हल्दी जो है वो ओरली, जितने भी पुरानी किताबें हैं उसमें जो बेस्ट वे है उसका बर्न के केस में वो ओरली हल्दी को देने का है। इसी तरह से फिटकरी का रोल है, फिटकरी को भी ओरली जो है वो दिया जाता है। फिटकरी का जो एक्शन है जो मेरी समझ में आता है, मुझे नहीं मालूम, आई मे बी रॉन्ग क्योंकि मैंने इसके ऊपर काम नहीं किया, सिर्फ देखा है और ट्रेडिशनली इस्तेमाल होता आया है, और उसके एक्शन को देखते हुए ये बात समझ में आती है कि जो फ्लूइड लॉस हो रहा है सरफेस से, जो बर्न एरिया है उसकी सरफेस रॉ हो गई है, वहां से जो कैपिलरीज जो हैं वो ओपन हो गई हैं, वहां से फ्लूइड लॉस हो रहा है। फिटकरी से वो जो माइनर ओपनिंग्स हैं, जो माइन्यूट वेसल्स हैं, वो रास्ते उससे बंद हो जाएंगे। फिटकरी जो है वो बहुत अच्छा कॉन्ट्रैक्शन का, और कहीं भी ब्लीडिंग हो रही हो, आप माइनर ब्लीडिंग वहाँ फिटकरी लगा दीजिए तो वो बंद हो जाती है। तो फिटकरी का इस्तेमाल ओरली यानी सिस्टमेटिकली उसको अगर फिटकरी देंगे तो उससे जो लॉस ऑफ फ्लूइड है वो रुकेगा, कॉन्ट्रैक्चर होगा, और फ्लूइड वो जो है फिटकरी दैट विल हेल्प इन हीलिंग। ये एक चीज समझ में आती है, इट नीड्स रिसर्च, और उसको प्रॉपरली जो है जो भी एस्पेक्ट्स हो सकते हैं उनको इंक्लूड करते हुए फैक्ट्री पर रिसर्च होनी चाहिए। मुझे नहीं मालूम कि रिसर्च हो चुकी है, मुझे मिला नहीं, मैंने तलाशने की कोशिश की थी कि मोड ऑफ एक्शन फिटकरी का क्या हो सकता है। जो मेरी समझ में आया वो मैंने डिलीवर किया। नेक्स्ट इज रोगाने नेक्स्ट इज अकाकिया। ये जो गोंद होता है बबूल का, तो इसका बहुत अच्छा रोल है। इट इज यूजफुल फॉर फायर बर्न्स। खास तौर से इसको जो ट्रेडिशनल बुक्स में लिखा हुआ है दैट इज विद द एग वाइट पार्ट, जो उसका एल्बुमिन है एग की, अंडे की सफेदी के साथ। उसमें मुझे इसमें भी जाहिर है कि एक पहले तो एक हाइपोथेसिस होगी, बुक्स में जो लिखा हुआ है वो गलत नहीं है, हजारों साल से इस्तेमाल होती आई ये चीज। मोड ऑफ एक्शन क्या है, किस तरह से ये काम कर रहा है, जाहिर है कि अगर हम इसमें प्रोटीन की बहुत ज़्यादा ज़रूरत पड़ेगी, प्रोटीन की क्वांटिटी भी 1 ग्राम से 3 ग्राम तक जो है वो इसके अंदर इंक्लूडेड है चाइल्ड में या एडल्ट्स में। तो लोकल एब्जॉर्प्शन भी होगा, और मुझे लग रहा है कि कैपिलरीज जो हैं या जो एरिया बर्न का है उसको भी जो है एक इफेक्ट मिलेगा, वो थर्ड स्पेस में फ्लूइड जाने से रुकेगा। जो भी मोड ऑफ एक्शन हो, गोंद अपने आप में एक अलग काम करता है हीलिंग्स में, खासतौर से अल्सर्स की हीलिंग्स में, और क्रॉनिक वुंड्स की, नॉन हीलिंग वुंड्स की हीलिंग के लिए जो ये गोंद है बबूल का गेंद हजारों साल से इस्तेमाल में होता आया है। अब इनको भी जो भी लोकल एप्लीकेशन इनके बने हैं या अलग अलग सिंगल ड्रग्स पे एक्शन, वो जाहिर है स्टेराइल फॉर्म में ही, क्योंकि जो भी ड्रग्स हैं वो स्टेराइल होनी चाहिए। स्टेराइल फॉर्म में अगर इनका ऑल एस्पेक्ट्स जो भी हीलिंग के लिए, जो भी ड्रग के रिसर्च के लिए होते हैं, उनको इंक्लूड करते हुए इन पर रिसर्च की जा सकती है। मैं इतना फ्लुएंट इंग्लिश में नहीं हूँ, और ये चीज़ें चूंकि इन पर डिटेल बोलनी थी, बाकी तो जो रटा रटाया था या जो चीज़ मैंने तैयारी की थी वो बोला। ऐसे बीटेल नट, ये जो है ये इसको भी इस्तेमाल किया जाता है। ये खास तौर से जो कीलॉइड ना, बर्न के बाद एक बड़ी प्रॉब्लम जो है वो कीलॉइड की या कॉन्ट्रेक्चर्स की है। बहुत ज़्यादा हम लोग इस्तेमाल करते हैं, बहुत सारी दवाएं मार्केट में हैं कीलॉइड के लिए। क्यों ना जो बीटेल नट है इसके लिए इसको इस्तेमाल किया जाए, इसकी प्रिपरेशन जो है बनाई जाए, क्योंकि बीटेल नट के लिए जो बुक्स में लिखा हुआ है कि बर्न के बाद में जो हार्ड स्वेलिंग्स अपीयर होती हैं, तो उन हार्ड स्वेलिंग्स के लिए लोकल एप्लीकेशन के तौर पर इसको इस्तेमाल किया जाता है अलॉन्ग विद द रोगन जैतून। तो बर्न के बाद में भी, और जो जिन लोगों में टेंडेंसी है कीलॉइड की हल्का सा स्क्रैच पड़ा और कीलॉइड बन गया, पोस्ट बर्न तो कीलॉइड या कॉन्ट्रेक्चर होते ही हैं। उसके अलावा भी तो ये एक हमारे पास एक दवा का एक रास्ता है, एक मेडिसिन का, कि इसको रोगन जैतून के साथ कैसे तैयार करें, क्या करें। मैंने पहले ही बता दिया कि ये सारी चीज़ें मैंने बुक से और जो रिसर्च आर्टिकल्स हैं उनसे लिया है, लेकिन उसमें कहीं भी स्पेसिफिकली इसको एज ए ट्रीटमेंट यूज नहीं किया गया है। उसमें ये रिसर्च का सब्जेक्ट है। रिसर्च के लिए पहले मटेरियल इकट्ठा होता है, कुछ आइडियाज आते हैं, तो ये बेसिक आइडिया देने की मैंने कोशिश की है और ये बताने की कि in Unani medicine we may have so many solutions if we use all these drugs in sterile or in fully aseptic conditions after research. हिना के बारे में बहुत ज्यादा ओपन है। ये खुद ही एक एंटी सेप्टिक इफेक्ट रखती है, एंटीबैक्टीरियल इफेक्ट रखती है। उसके अलावा हिना जो है बर्न के लिए बहुत अरसे से यूनानी ही की दवा है। हिना यानी मेहंदी के पत्ते जो हैं वो इस्तेमाल में आते हैं। बहुत सारे इसमें ऑयल्स के साथ प्योर एक्वस बेस्ड भी लगाया जा सकता है और ऑयल बेस्ड एप्लीकेशंस भी हिना के तैयार किए जा सकते हैं फॉर लोकल एप्लीकेशन। इनाबो साला अब इसमें जो है इसको कहा गया है कि ये एक तरीके का एक लेयर का काम करती है और इवन ये कि इसको सिस्टमेटिकली भी या ओरल रूट से भी इसको इस्तेमाल किया है। सब ओरल एंड टॉपिकल यूज दोनों तरह से इसका इस्तेमाल जो है वो किया जा सकता है। एक लेयरिंग के तौर पे ये काम करती है, सूदिंग इफेक्ट के तौर पर। और फर्दर जो है इसका क्या मोड ऑफ एक्शन है, लेकिन बर्न में इसका जिक्र है कि इसका जो है लोकल एंड यानी टॉपिकल एंड सिस्टमिक इसको इस्तेमाल किया जा सकता है। खुबबाजी की जो पत्तियां हैं उनको रोगन जैतून के साथ, देखिए जितनी भी मैं अब तक दवाएं बताई उसमें मैक्सिमम दवाओं को जो इस्तेमाल किया गया है वो रोगन जैतून के साथ इस्तेमाल किया गया है। तो रोगन जैतून का एज ए होल भी कुछ ना कुछ रोल इसमें रहा होगा विच इज टू बी एस्टेब्लिश्ड। वाइनेगर, जाहिर है कि वाइनेगर के बारे में जाहिर है कि अपने आप में ये एक तरीके का एंटीसेप्टिक भी है, एंटीबैक्टीरियल भी है। इवन ये कि जो बर्न वुंड्स हैं उनको क्लीन करने के लिए भी इसका इस्तेमाल होता रहा है, जो क्रॉनिक अल्सर्स हैं उसमें इस्तेमाल होता रहा है, और जो बर्न वुंड के अंदर जो कीड़े हो जाते हैं उनको दूर करने के लिए इसका इस्तेमाल जो है वो होता रहा है। काफूर का इस्तेमाल सदियों से होता रहा है। कैम्फर, काफूर एज ए सिंगल ड्रग भी इसका इस्तेमाल होता रहा है, विनेगर के साथ भी इसका इस्तेमाल रहा है फॉर टॉपिकल एप्लीकेशन। और इसका एप्लीकेशन जो है सबसे आसान दवा जो समझ में आती है जो बड़ी कॉमनली यूज्ड है वो ये तीन ही दवाएं हैं। एक सबसे आसान कहा जाता है कि आप फिटकरी का दूध पी लो, उस पर रिसर्च होनी चाहिए, इफेक्ट करती है, इवन पेन को भी रिड्यूस करती है। उसका फिटकरी का जो एक इफेक्ट जो मैंने बुक्स में देखा वो एनाल्जीजिया भी है किसी हद तक, तो एनाल्जेसिक इफेक्ट दे रही है, कैपिलरी परमिएबिलिटी को वो कम कर रही है, उसके साथ साथ जो है वो लोकल सुकेड़ भी रही है। अब ये तो सब मैं अपने पास से बोल रहा हूँ। तो जो ये बताना चाह रहा था कि जो कॉमन जो है उसमें काफूर का भी इस्तेमाल है। काफूर, हल्दी, फिटकरी इतनी कॉमनली होम रेमेडीज हैं कि दे नीड टू बी, देयर रोल इज नीड टू बी एस्टेब्लिश्ड। साइंस का जमाना है, हम लोग इंस्टीट्यूट्स में मौजूद हैं, क्यों ना इन दवाओं को बहुत अच्छे से इनके निगेटिव्स और पॉजिटिव सारी चीजें लेकर के इन पर इंडिविजुअल और एज ए कलेक्टिव रिसर्च की जाए, और अलग अलग इंस्टीट्यूट्स को NIUM अलग रिसर्च करे, कुछ दवाओं पे हम लोग रिसर्च करें, कुछ कोलैबोरेटिव हो, और हम क्यों ना यूनानी में ऐसे ऑइंटमेंट्स और ऐसी चीजें जो कम से कम उन केयर को, जाहिर है उन केयर के लिए हम उसका जो IV फ्लूइड्स है और जो क्रिटिकल केयर है उसका अल्टरनेट हम इमीडिएटली नहीं ला सकते, बट वी कैन एड मच इन द मैनेजमेंट ऑफ बर्न केयर। तो काफूर भी बड़ी पुरानी दवा है। कोरिएंडर जो है इसका भी इस्तेमाल है, ये भी विनेगर के साथ इसका बुक्स में जिक्र है, बर्न वुंड के केयर के तौर पर इसका रोल जो है। लिसानुल हमल, ये जितनी भी आग देने वाली चीजें हैं या जितने जैसे कहते ना बर्निंग सेंसेशंस, बर्निंग सेंसेशन हो रहा है, बर्न के बाद में तो बर्निंग सेंसेशन होगा, बर्न से ही वो बर्निंग बनी। इवन इसके अलावा भी अर्टिकेरिया वाली कंडीशन है या हर्पीस की कंडीशन है। यानी कहने का मतलब ये है कि हम जैसे वहां पे यूज कर रहे थे, जितने भी बर्न वाली केयर के ऑइंटमेंट्स आते हैं उनमें एनेस्थेटिक एजेंट्स भी होते हैं, उनके अंदर जो है वो एनाल्जेसिक्स भी होते हैं। तो क्यों ना लिसानुल हमल जो प्योरली यूनानी ड्रग है उसको सामने लाया जाए और उसके एप्लीकेशंस जो हैं वो तैयार किए जाएं। संदल बहुत आसानी से लोग यूज करते हैं संदल। अब प्योरली संदल मिल जाए, अब जरा मुश्किल हो गया है प्योर संदल का, लेकिन अगर मिल जाता है बुरादे संदल, अब ये किस फॉर्म में हो, माइक्रोफाइन फॉर्म में होना चाहिए। बेटर है कि संदल जो है वो जो नैनो टेक्नोलॉजी है उसके थ्रू जो है संदल के ऊपर जो है वो काम किया जा सकता है। संदल जो है उसका अगर इफेक्ट्स को देखें, आप इसके इफेक्ट्स को निकालिएगा और इसको देखिएगा तो बहुत यानी माइनर लेवल पर ये एनाल्जेसिक भी है, लोकली जो है ये जिस चीज को हम कहना चाहिए, अब पोटेंट तो हम नहीं कह सकते इसको, लेकिन लोकल एनेस्थेटिक, इसका किसी हद तक लोकल एनेस्थेटिक इफेक्ट भी है संदल का। संदल एंटी बैक्टीरियल भी है। तो इस तरह की चीजें, और अगर बरसों से इस्तेमाल में होती आ रही है तो हो सकता है कि हीलिंग के जो फैक्टर्स हों उनको ये प्रमोट भी करती है। तो इसके रोल को भी एस्टेब्लिश करना जरूरी है। इसमें एक चीज जो मेरी समझ में आती है कि संदल का जो पाउडर हम लोग यूज करते हैं वो पाउडर इसमें इफेक्टिव नहीं होगा। इसमें नैनो टेक्नोलॉजी माइक्रोफाइन पाउडर जो है संदल का, टॉपिकल एंड ओरल, संदल जो है वो ऐसी दवा है जिसको ओरल भी इस्तेमाल कर सकते हैं, टॉपिकल भी इस्तेमाल कर सकते हैं। अर्क गुलाब, गुलाब का जो गुलाब के बारे में, गुलाब से क्लीन कर सकते हैं। अभी इतनी सारी चीजें ऊपर बताई क्लीन करने के लिए, क्यों ना हम अर्क गुलाब से उसको क्लीन करें। अर्क गुलाब उसको पहले चेक कर लिया जाए, या फुल्ली एसेप्टिक कंडीशंस में अर्क गुलाब को कलेक्ट किया जाए, उससे उनको क्लीन किया जाए। जितनी हमारी प्रिपरेशंस बने वो अर्क गुलाब में बने। अर्क गुलाब जो है ये पता है, बिल्कुल नोन है कि एंटीसेप्टिक है इसका इफेक्ट, सूदिंग इफेक्ट है, और बहुत सारे इफेक्ट्स निकल के आएंगे जो मुफरदात और मुरक्कबात इल्मुल वाले बहुत सारी चीजें इसमें ऐड करेंगे। जैतून के बारे में मैंने पहले ही बताया कि अक्सर प्रिपरेशंस में जैतून का इस्तेमाल है। तो इसमें एज ए मीडियम जो चीजें, ज्यादातर जो चीजें दिख रही हैं, एक तो इसमें विनेगर का इस्तेमाल उसमें आया, इसमें जैतून का इस्तेमाल समझ में आया, गुलाब का आया। तो इतनी सारी चीजें हमारे यहाँ हैं जिनका हम इस्तेमाल जो है इसमें कर सकते हैं। मेरे हिसाब से ये जो पार्ट है यूनानी ड्रग्स का, ये इस लेक्चर का सबसे इम्पोर्टेंट पार्ट है। बाकी सारी चीजें जो हैं वो बुक्स में भी अवेलेबल है, मैंने कोई नई चीज इसके अंदर नहीं डाली। और हम सारी चीजों को यूनानीनाइज्ड नहीं कर सकते, क्योंकि वो चीज जो भी है, टेक्निक है, फ्लूइड देने हैं तो हमें देने हैं, उसकी आईवी न्यूट्रिशन उसको देना है तो आईवी न्यूट्रिशन देना है, क्रिटिकल केयर के जो भी एस्पेक्ट्स करने हैं वो जाहिर है उनकी देन नहीं है, वो एक टेक्निक का और एक साइंस का एडवांसमेंट है। लेकिन ड्रग्स आप देखिए कि ड्रग्स हमारे पास, ये मैंने कुछ ड्रग्स ली हैं, देयर आर मोर देन 3 टाइम्स इसमें
अरे वीडियो कैसे
न्यूट्रिशन के
बंद
लिए
हो
भी
गई
हम
थी सर?
इंक्लूड कर
कोई आ
सकते
गया
हैं।
है? वीडियो कैसे बंद हो गई?
Okay, continue, sir. शकील साहब देखिए।
जी सर, अस्सलाम वालेकुम। सर, आपकी आवाज नहीं आ रही है।
आपकी आवाज नहीं आ रही है सर।
जी सर।
हेलो, मेरी आवाज आ रही है?
हाँ जी सर, आपकी आ रही है,
हाँ,
शालम
वो
सर
एक
की नहीं आ
फोन
रही
कॉल
है।
आ गई थी, उसकी वजह से डिस्ट्रप्शन हो गया। मैंने मोबाइल इंटरनेट से कनेक्ट किया हुआ था।
थैंक यू वेरी मच सर, थैंक यू वेरी मच।
आवाज आ रही है? नहीं, आवाज नहीं आ रही है।
मेरी आवाज नहीं आ रही?
आपकी आ रही है।
आपकी
आ रही है।
शकील भाई की नहीं आ रही।
Thank you, Professor Tafsir Ali sir, for your explanatory, detailed, and nice presentation on burn waste management. Now, our respected speaker sir is available for any query from participant side. Please, question, please.
Mashallah.
Any. Any question from participant, please ask your queries. Our respected teacher is available with us.
Sir, what is the role of Unani?
ऑलरेडी टोल्ड।
यूनानी ड्रग्स का रोल, जैसा कि मैंने पहले ही बताया, कि इन केस ऑफ माइनर बर्न्स और सेकेंड डिग्री बर्न विच इज हैविंग लेस देन 10% or less, I can say that not severe but minor to moderate burns. Critical patients, in critical patients we cannot apply the Unani medical aspect. We can apply in cases of minor burns or moderate burns. We can apply for the care of wound care के लिए। अभी इतनी चीजें मैंने बताई। Still the topic whether the Unani drugs can directly be used is the topic of debate, is the topic of research. Proper research is to be
Sir,
done.
one thing. What is the grafting measures in skin burn patient? If there is any burn, so how it is possible to graft it or not?
Skin grafting is actually, I am not included in this lecture, but I can speak on this topic because that is very specifically the subject of the plastic surgery. The wound which is having a specific, the surface area more than the limit that needs skin grafting, and that skin grafting according to the depth, maybe partial thickness or full thickness skin grafting. Before applying the graft, the area, burn area or the wound area should be able to take up the graft. That should be healthy. That should have healthy granulation tissue that is ready to take up the graft. Otherwise, rejection may be there. Better to prepare the patient or to consider the patient according to the norms of the skin grafting. In cases where skin graft is not available, there are certain other methods which can be applied, certain applications. If we will not use this method, the wound may be bigger and bigger, may have infection and may lead to complications and may be fatal.
Shakil sir.
Thank you very much, sir. Any other question from participant side? Okay. Now we will proceed.
So there are two questions from Rabba and Habib.
Okay, Rabba. Please ask your question. That is available.
Assalamu alaikum, sir. Sir, in case of chemical burn, how can we differentiate the burn is either from the acid or alkaline?
Whatever burn is there, in case of chemical agent, there will be history. First of all, there will be history. What was the nature of the chemical? Another aspect is that acids cause more damage, more deep burns. In case of chemical burns, whatever we see from the surface, we cannot have an idea how much damage has occurred in the depth. In case of acids, there is more damage, the damage up to the more depth in comparison to alkaline. Further, in case of treating the burn, chemical burn, if it is from acid, there is no need to use alkaline. If we use alkaline, that will further damage, that will give further damage. एसिड से तो बर्न हुआ है, एल्कालाइन ने भी बर्न कर दिया. उसके लिए बेटर जो है वो जो भी एसिड ने हार्म किया है उसको डाइल्यूट कर दिया जाए, और दैट इज द बेस्ट वे इज द जो भी जितनी चीजें बताई, खासतौर से स्टेराइल वाटर और नॉर्मल सलाइन जो है, दैट इज द बेस्ट वे. और इसमें मुझे ऐसा लगता है कि अगर स्टेराइल अर्क गुलाब मिल जाए तो वो बहुत अच्छा होगा. इसमें चाहे एसिड से बर्न हो या एल्कलाइन केमिकल से बर्न.
Sir, we can use litmus paper also, right, sir, to differentiate whether
that litmus paper can be used to ascertain whether it is acid because of acid or because of alkaline. But that there may be no need of such test, because I already told that history is most important. In case of child or unknown type of burn, we can use it.
Shakil sir.
Thank you very much, sir, for your satisfactory reply of our query from our participant side. Thank you very much, sir. Now we will proceed to the second lecture of this webinar. Topic of this second topic is fishery nano treatment updates. Where do we stand in 2022? As we know that the incidence of anal fishery is around 1 in 350 adults, occurs most often in adults aged 15 to 40 years. Fishery nano is a very common condition, and its striking presentation is the sharp acute pain in the perineum. It is a radial split in the anodome, which is causing the pain. Acute anal fissure arises from the trauma caused by the strained evacuation of the hard stool. Perpetuation and chronicity may result from repeated trauma to the anal canal. Constipation may develop secondarily because of the fear of recurrent pain. Therefore, in today's webinar, there will be a detailed deliberation on this quite interesting and a common problem of Indian population by our second speaker of this webinar, and he is Dr. Firdaus Ahmad Najar, Assistant Professor, Department of Ilmul, Jarahat, NIUM, Bangalore. I would like to introduce to our participant Dr. Firdaus Ahmad Najar has completed his BMS and MS from AKTC NU Aligarh. After completing his master's, he joined the project of CCRUM as SRF. After that, as a medical officer, he joined his hometown, Kashmir. In 2012, he joined this department, that is the Department of Ilmul, Jarahat, NIUM, Bangalore, as a faculty member. Dr. Firdaus Ahmad has around 30 publications in national and international reputed peer-reviewed journals. He has attended and presented papers at more than 40 national and international conferences and seminars. Dr. Firdaus Ahmad Najar actively participates in the academic activities of the Department of Ilmul, Jarahat, and NIUM, Bangalore. He is a good teacher, an efficient researcher, and a humble and bold surgeon. Really, he is a bold surgeon, and he is always available at the forefront in completing any allotted task. In fact, he has played a very important role in the
Assalamu alaikum.
Walaikum assalam.
Am I audible?
Please, Dr. Firdaus.
Okay, sir. I will share my screen. Okay. Can you see my screen?
Yes, sir. It's visible.
Okay. Thank you. Thank you, Shakil Bhai, for a wonderful, beautiful introduction. Thanks Almighty Allah, and thanks Director NIUM for providing this platform, and organizing committee for giving me an opportunity today to speak on this topic. And it is my pleasure today to share this topic, to share this platform today with my teacher, Professor Tafsir Ali sir, although virtually, but I could hear him and I could listen to him after a long time. After COVID, the paradigm has almost shifted to the virtual mode from the physical mode. And although the conditions are dipping back to the normalcy, but still we have almost adapted this virtual mode.
आवाज
बस-
थोड़ा कम आ रही है सर, आवाज थोड़ा वॉल्यूम बढ़ा
हेलो
दीजिए सर,
हेलो
वॉल्यूम थोड़ा सी बढ़ा दीजिए सर।
जी जी अब आ रही है
No, you are clearly audible, no problem. Dr.
Okay,
Feroz, you are
okay.
clearly audible.
Okay sir, okay. Yeah, I was talking about the conditions are almost coming back to the normalcy, but still we have almost adapted this virtual mode. But this virtual mode is adding miseries to the human life slowly and simultaneously, which we are not aware about this thing. That are lifestyle disorders, because we have altered lifestyle now. And this lifestyle has conquered many of our systems other than cardiovascular, and now the victim is the proctology or the anorectal system. Many of the anorectal diseases are supposed to be now due to the this altered lifestyle, and one among these is fissure in ano. I have been given this topic, this task to discuss about the fissure in ano. I will be discussing the treatment treatment updates which are available with us right now. So my talk will contain. Is my screen visible? I'm not able to move it.
Visible it is.
Only first slide is there.
Yeah. Oh,
Only first slide is there.
It is not rolling.
okay. It is not moving ahead. Yes, madam. I am trying to share it.
Maybe you can change it. This is only first slide.
Huh?
Go to second slide.
Okay.
Many you can go, no problem.
Is it okay now?
It is only
Yes.
first slide. Okay.
Yeah. Okay. Thank you, madam. So my topic is fissure in ano treatment updates. Where do we stand in 2002? We'll be discussing the many aspects of fissure and the treatments available right now with us. So the contents of my today's talk are understanding fissure in ano. So we'll be discussing this, where the fissure occurs, how it occurs, what are the causes behind it, and what is there in Unani literature about the fissure in what is there in Unani system of medicine about the fissure in ano. Then I will discuss what we have taken, what research we have taken about this fissure in ano in NIUM. Me and my colleagues have taken some research clinical trials among this Unani literature which is available with us. Then we will be discussing the many treatment options which are available right now from different system of medicine, from conventional to Ayush system. And then we will be discussing what option is better for a patient, and what you have to suggest, and where he can go for this. And finally, we will conclude with a small discussion. So first, we will understand the fissure in ano. It is in Unani system of medicine. It is mentioned as Shukakul Mata. So for understanding fissure in ano, we need to have a quick look at the anatomy of the anal canal. So I will be discussing the anal canal. Anal canal, you know, it is 4 centimeters in length, the distal part of the GIT system. So these you can see here the anal canal. These are the sphincters, external sphincters. It has 3 parts. This is the subcutaneous part, and this is the internal sphincter. This is the internal sphincter, and these are the anal sinuses. You can see anal columns, and these anal columns form the dentate line here. This is the dentate line. It is of importance here, this dentate line. And this is the middle part of this is the upper part of the anal canal, this is middle part, and this is the distal part. This is outer part. This here you can see one line. This is the white line of Hilton, which is a groove, actually a groove between the subcutaneous part and the internal sphincter part. So actually the fissure is formed here from this below this dentate line, and above dentate line we have parasympathetic nerve supply, and below we have somatic nerve supply. So this was a quick look at the anatomy of the anal canal. Now the fissure, term fissure. If you see the term fissure, it is actually a Latin word, means a groove, a division, a cleft, a slit, or a furrow. You can see here in the picture, it's showing the exact what is the fissure. So it can be, therefore, it can be defined as longitudinal tear at the distal end of the anal canal, extending from dentate line towards the anal verge. So if we discuss now how is caused, the etiology of this fissure in anal, it has been divided in two parts mainly. One is primary cause and the secondary cause. The primary is idiopathic, what we say that etiology is not known, and secondary is in response to any underlying disease. So first we will discuss the primary causes. What are the primary causes of the anal fissure? The first and foremost cause is idiopathic. What we call it idiopathic, unknown pathology is there. This is the most accepted one. But still some causes have been postulated there. Some like first and muscle spasm of the anal canal. Less elastic endoderm is there. Posterior commissure is less well perfused. Posterior angulation of anal canal. Relative fixation of anal canal posteriorly. Spasm of internal sphincter of anal canal. Then pregnancy and labor is also proposed a cause. Persistent diarrhea and constipation. These causes have been or the possible causes are these. But if we see from point 2 to point 7, number 2 to number 7, these causes are related to the anatomy or physiology of a human being. So if these are the causes, then every individual should have suffered from this fissure in anal. But as we know, every individual is not suffering from this problem. So, and pregnancy or labor, we know that not every pregnant lady or every lady who gives birth to a child is not suffering from fissure in anal. Then persistent diarrhea or constipation. Persistent diarrhea may be there due to some underlying cause, or constipation may be there due to some underlying cause, or lifestyle, altered lifestyle. So I mean to say here that these, if the human anatomy, human physiology is same, so every individual is not suffering from this, then what is the reason behind this? Why this group of a few percent of population is suffering from this problem? So there are some other causes who are at risk, other causes, risk factors, which aggravate this problem, this spasm and this less perfusion of the area, or this diarrhea or constipation. So this is actually number one is less hydration. Number one is less hydration. We can see the people who remain busy in their work or labors, or even we have observed some cases we have come across in our OPD, like the call center boys who are working on call centers. They usually remain less hydrated because they cannot leave their seats. They cannot leave their seats frequently for washrooms. So they'll remain less hydrated, and ultimately they come with this problem. Many more problems, but this problem is also found in them again. Another is excessive exercise. Excessive exercise means when it is not only related to gymnasium. Excessive exercise who are running throughout the day in either riding bicycles, either riding horses or bikes. So they also suffer from this condition. And they have it has been also reported that those people also suffer from this. Then prolonged sitting. Prolonged sitting is like we have seen tailors or in offices who work for 8 hours or 9 hours continuously or sit for a long time. They also come with these problems. Use of junk foods. So people who are very much busy in offices or throughout the day, they don't get time to have lunch or dinner, and so they use junk food. They also suffer from this problem. Then obese persons also. So if we see these things, these actually these are the things which aggravate the previous causes I have mentioned in idiopathic under this primary cause. These actually aggravate those things. All these, if we see, it can be incorporated in our this asbab sitta zururia, the 6 essentials of life. This is the derangement of this asbab sitta zururia, because see, you can see the less hydrated under the maful mashroob, excessive exercise. You can it is this harkat badnis, harkat wa sukoon badni. Prolonged sitting is coming also under this. So these are all, these can be incorporated under the heading and this 6 essentials of our body. When these are disturbed, it aggravates the other factors. Either there is less perfusion, or there is constipation, there is diarrhea, whatever may be. That these aggravate the causes that results in the primary fissure. Then there is secondary anal fissure. Secondary cause of the anal fissure, it is rare, it is 1%. It is found in these diseases which are mentioned here, the systemic diseases. You can get the history at the moment while you face such patients. You will find the history also there. What is the pathophysiology, how it occurs? Do any of the above mentioned pathology, this cause will be there? It will cause a micro trauma. And due to, for example, there may be constipation, there may be a micro trauma. That trauma is very painful in this anal because of the somatic nerve supply. That acute, that causes the acute anal fissure. That is very much painful. That pain initiates the internal anal sphincter spasm. This pain leads to the high resting anal pressure. That is the squeeze, the internal anal sphincter is squeezing itself. That squeezing leads to less perfusion, means less blood supply of this area, and that leads to local ischemia. That local ischemia is leads to poor healing, and ultimately it sets up a vicious circle. So during treatment, what we have to do, we have to break this circle anywhere. We have to break it here, anywhere from this pain or before spasm. So when this circle will be broken anywhere, so it will automatically heal. The pressure, this fissure will automatically heal, and the pain will subside. So depending on the duration, it has been divided into 2 types, acute and chronic fissure. Some authors have mentioned less than 8 weeks, the fissure is present. If the fissure is present from less than 8 weeks, it is acute. And some have mentioned it 6 weeks, or some have mentioned 4 to 6 weeks. So this is not only the duration, the presentation of the fissure is also there. It is important. You can, while you will examine the patient, this acute fissure will be very fresh, and it will be very much painful for the patient. And this, while you will examine the patient, it may ooze. While you will apart the buttocks for inspection, it may ooze out. Little bleeding may be there. In comparison to chronic fissure, there will be this less. It will be less painful. Pain will on and off there. Pain will be there. There will be hypertrophic papilla. There will be sentinel pile, and there will be fibrosis for the fissure also. So how will you diagnose this patient, this fissure? It is very easy to diagnose this fissure. Like you can diagnose it from symptoms, which is the history from the patient that will tell you, and next clinical examination. It's very easy, but it is somewhat challenging here in this Indian subcontinent. But here in India also, it has been reported that in Indian subcontinent, the people usually shy, or people are usually shy, and they don't want to expose this area, the pudendal area, or this rectal area to the patient, or even some patients do not reveal this problem to their near ones till late, and they only consult the doctor when it is very much painful, or when it becomes unbearable for them, or it all alters their daily routine work. Then only they consult a doctor. But one more thing is there. We have at some peripheries, or in some clinics, or our clinicians don't have such facilities. Do not have such facilities to examine the patient, or they cannot convince the patient for examination. We even face this problem here. 1 to 2% patients do not agree for the examination. So the same problem is the peripheral health centers or clinicians, where patients do not agree for the examination, or they don't have the facilities, so the patient do not want to reveal his privacy there. So that remains a problem also. Or some of the clinicians or practitioners who are working in peripheries do not know how to diagnose this problem, how to examine a patient correctly. So when often we receive patients, so he comes with a diagnosis, a preformed diagnosis, self-formed diagnosis of piles. Or for every rectal case, he comes with a diagnosis of piles. Doctor, I have piles, and I am using this ointment. For a common ointment, they are using for every per rectal problem, be it abscess, be it fissure, be it fistula, be it hemorrhoids. So diagnosis you can make by 2 symptoms and from examination. So the first, patient will come to you with pain. This pain has been described as passing the pieces of glass. It is so sharp pain. The pain it lasts from hours to full day. Whole day the pain may be there. You can see this. It hampers the daily routine of the patient in offices, and even housewives have reported that we are not able to perform our daily routine work at home while in pain. Then second is bleeding. Bleeding in fissure only. If there will be fissure only, it will be in the form of streak on pieces. But patient may complain of bleeding, more bleeding, But it doesn't mean he does not have fissure. He may be having associated hemorrhoids also, or any other proctological problem. So we need to examine it properly for inspection or digital examination or whatever is possible. Then third is the itching. The patient will complain of itching throughout the day while in work, while in office, or while at home. So next is the clinical examination. When patient will come to you with these complaints, you have to examine the patient. You will examine the patient in, there are different positions according to the convenience of the patient. And for this, you have to maintain the privacy. You need a, for a female patient, you need a female attendant or a nurse along with you. So the positions here are shown. This is the left lateral position. You can examine this, the ideal position, then knee elbow position. You can examine in this position, and you can examine in the dichotomic position also while in operation theaters. So this will, while examination, you have to just make the patient lie down and make the buttocks apart. If it is acute fissure, it will surely, there will be more spasm, there will be, it may ooze out at the moment while you make the buttocks apart, and it will be more painful. Digital examination may or may not be possible sometimes, and proctology, this proctoscope is purely contraindicated in acute fissure, otherwise patient may go in shock. But in chronic fissure, if there will be a chronic fissure, you can easily examine it for the digital as well as you can go for proctoscopy also. So while examining, you can see this, it may be the anterior fissure, it may be lateral fissure, it may be the posterior fissure. It has been, the anterior is present in almost 10%, posterior is present in almost 90% of the people. So what is prevalence and what is the incidence? Not much data is available about this prevalence and incidence of the fissure in NO. After searching the data, we have found one study was taken in 2013 here in NIUM hospital, a cross-sectional study where he has enrolled 460 patients. He could found 15.62% of patients were suffering from, among the proctological cases, among the rectal cases, 15.62% were suffering from anal fissure. Then in 2015, I myself did a retrospective study for, I found that 9.8% or 10% of patients from proctology where proctological cases were suffering from anal fissure. Another study was taken by Professor Said Shah Alam and my colleagues in 2017. They have enrolled. It was also a retrospective study. They have 36.20% were anal fissure patients. Another study in a Bhopal Medical College, they have found 17.81% of patients were diagnosed as anal fissures among the proctological cases. The incidence in America, it has been, it was in 2014, it has been reported that 342,000 patients reported with acute anal fissure. So this overall, if we see the 10% population or the 15% population, if we see it is a large population, and all their daily routines are also hampered. So it is alarming, and we need to have. Yeah. So what is there in Unani literature and available? What our Unani scholars have mentioned in their books? I will be discussing this. Rabban Tabari in his book Firdausul Hikmat has almost all Unani physicians have mentioned this fissure in their texts. Rabban Tabari has mentioned about the fissure that it is due to the morbid waste that descends towards the anus. And he has mentioned the treatment also in the form of ointment. It can be which can be formed by Murdar Sang, Tafeda Kashgari, and Dogan wool. Then Ismail Jurjani has also mentioned in Khwarizm Shahi the causes of this fishery nano. This is dry temperament, dry feces, or the tortuous anal vessels which rupture there and due to engorgement of the blood. And he has mentioned the treatment in the form of venesection and cupping also, venesection of the basilic vein and the cupping of the cupping between the buttocks. And then he has also mentioned the local marham, also local ointments for the this fissure. Then Zakaria Razi has also mentioned about this fissure in ano. He has mentioned that it is very difficult to treat this condition because it is sensitive. The part is very sensitive. The faces are passing from this canal, so medication is also applying medication becomes also difficult. Still, he has advised the treatment. He has denied the use of Qabid Adviya because it aggravates the condition, and he has clearly mentioned the mineral origin drugs and the Bharid Yabis drugs are beneficial in this condition, like Isbidaj Murdars and Shibi Yamani Kundar. And another patient, Sheikh al-Rais Ibn Sina, has mentioned in his text in Canon of Medicine, that it's a crack in the anal canal. He has mentioned the causes. It is yubusat and hararat, local yubusat and hararat in the anal canal. And it is due to the passage of dry feces. If there is yubusat and hararat, dry feces cause this crack, or it is varmihar, or it is due to the morbid and dry waste material coming towards the anus and engorged vessels in the anal canal. He has mentioned the treatment should be, those drugs should be used which are having wound healing property or laxatives and stool softeners. Muhammad Azam Khan has summarized this whatever his predecessors have written on about this fissure. He has also mentioned in Tafsir Azam that Yabus and Harat are the causes of this fissure in anal region by passage of dry feces, consuming non-fibrous foods, or sitting for long time causes more dryness and roughness of stools, and passage of these stools near the anal canal causing fissure in anal. Ibn Hubal Baghdadi has mentioned that this is due to Yabusat and Hararat, and we need to correct the temperament. We need to administer mucilages. We need like Isabgol, and he has also advised the Sharbat Banafsha, Sharbat Nilupar. He also made if the condition is chronic, then you can rub it vigorously until it bleeds. Then you can apply the ointment. Means this rubbing means what we call the fissurectomy. Means we have to make it fresh and then let it heal. Najibuddin Samarkandi has also mentioned that it is due to Harat and Yabusat and passage of dry feces. He has mentioned the treatment in the form of marham and suppository also, and Shizbak also, with some drugs like Mazu Gulnar. Then Ibn al-Kuf has also mentioned that we can give, in such condition, we can give multiple laxatives multiple times. Hammam, he has also mentioned the Turkish bath. He has also mentioned some prevention that do not avoid excessive work, avoid excessive sweating, and avoid also more fasting. And he also mentioned that if all this will not work, then rub it vigorously so that it bleeds out and then let it heal. He has also mentioned that use laxatives and foods causing constipation. Akbar Arzani has also mentioned, he mentioned that acute inflammation of anus, this is acute inflammation of anus with raised edge of the fissure and severe anal pain. He has mentioned some types of the this fissure according to the these types are actually depending on the cause of the fissure or the presentation. First, he has, if there is dryness in anus similar as dryness in extremity, which cause crack in anus. This he has mentioned one. This second is engorgement of vessels will be there, which shows congestion there. Third, Jarahat and Yabusat may be there, which causes sui misaj har ya this locally. Then hemorrhoids may cause also fissure, and passage of dry this morbid waste towards the defecation or towards the anal canal causes this fissure. So he has also mentioned the treatment in the form of venous section over the saphenous or basic vein and lower back cupping, and also mentioned the some local marham prepared from Safeda, Murdar Singh, Ilmul, and Katira. Tabari has also mentioned the about the fissure, the treatment of the fissure in the form of ointment from prepared from Murdar Singh and Mukil, Gulnar, Safeda, and he has also mentioned that if it is hard, you have to give the drugs which will act quickly, and if it is soft, then treat with the ointments only. Means he has differentiated somehow between acute and chronic fissure. Then the treatment also simultaneously. Majusi has mentioned the treatment of the fissure in the form of ointments prepared from the Safeda, Murdar Sang, Luban, Alam, and other drugs. So, if we summarize all this discussion where our Unani scholars have mentioned, we can we can summarize it in the way that they have mentioned the causes like passage of hot stools or use of kushk or turush giza, local trauma, akal khil, harji barudat, prolonged sting, and bawasir and nausea. Again, we can see this is coming under the headings of this 6 essentials of our Unani system, that is asbab tazuriyya, like harji barudat, prolonged sting, and trauma, use of kushk and the turush akal khil. So these are the causes according to this discussion, and this may be and then presentation will be the according to this presentation of this problem will be like this. Patient will come with pain, patient will come with bleeding, and you can find this yabusat here. Yabusat, you can what is yabusat? Patient will be there will be itching, and if you examine such patient, there will be spasm. That is due to the yabusat, and there will be an apparent shock of ankle, that is ulcer. So in this what our literature is available in Unani system of medicine. So our department has taken some studies, tested the preparations, had conducted some clinical trials in our hospital. So I will briefly discuss about those studies. In 2016, Dr. Mahjubin Fatima took a study on marham henna on 30 patients for 21 days. And she could find a significant improvement in pain, healing, and teaching within this time period in 21 days. Then in 2017, our colleague, Dr. Man Shakil, took another study on Elva powder. It was sprinkled on the fissure daily for 4 weeks, and there was complete healing of the fissure. The paper is published in Elsevier also. I took a study on the fissure in the same year, 2016, since we are getting a good number of patients in our OPD. So there is no problem. I took this in same year. I took the ointment of Murdar Sang, Safeda, Rogan, Bull, and I found that 28 patients healed within 2 weeks, and only 2 patients remained we showed this healing in 3rd week. Then another study, I took another study on acute fissure. Those who were the first episode, having first episode of fissure, I used the decoction of babuna, as, and shahad in the form of decoction as sitz bath. And believe me that all patients showed good response, and in 2nd week, all patients showed healing in acute fissure. Then 2019, marhum kafui was used in both acute as well as chronic fissures. 85% cases are healed in 3rd week, and remaining 5 took 4 weeks to heal. Another study in 2020, a comparative study of this safedab and diltiazem was completed recently, where we found that the test group, the patients healed in 3 weeks. So my aim is to present here this study, the clinicians who are working on therapies or in this who are in practice, they can test, they can use these ointments, these prescriptions, they can make these prescriptions on their respective clinics, they can use easily. So this was about the Unani, what is there in Unani, what you can do, and now the treatment updates, what other treatment options are available for the patients. In conventional medicine, we can see there is surgical as well as medical treatment available. In surgical, we have dilatation, we have lateral internal sphincterotomy, we have angioplasty, hysterectomy, fissurotomy, and lasers, laser now available. And medical, we have some ointments and injection also, botulinum toxin in the form of. In Ayush system, we have Ayurveda. Ayurveda is doing both surgical as well as medical management. Unani is doing both Ilaj bil Yad as well as Ilaj bil Dawa. And Siddha is having only the Siddha, they consider only the medical management. And homeopathic is having also a long list of medicines available for fissure and anemia. We'll be discussing one by one then shortly. The first and foremost thing for any fissure, whether it may be chronic, whether it may be the acute, or whatever the pathy we have, every conventional or Ayush system of medicines prescribe this one for every patient. This is increase intake of dietary fiber in the form of fruits, in the form of green leafy vegetables, or bulk form. And sufficient hydration should be there. Otherwise, the medicines or this will not work if there will not be sufficient hydration. Then stool softeners in the form like Mulainath we have. We can give him Mulainath also inside, and then sitz bath also. Sitz bath is important. It gives some relief from the pain immediately. If the patient, you can advise patient, if he after defecation, when he feels pain, he can immediately go for sitz bath at least for 10 minutes. He will surely get relief. And we don't, there is no need to add anything in the water. Only lukewarm water is required for this. No, like many of clinicians use astringent drugs like Kaviz Adviya, which have been avoided by some of our physicians because it causes local dryness and it causes more itching in there. In conventional medicine, then we have this nitroglycerin. It is locally, it can be applied. It is a neurotransmitter. It causes relaxation of the internal anal sphincter. It is having good healing rate, but it takes usually 6 to 8 weeks for a patient to heal. It is the healing rate is slowly, and there is headache was reported in 27% of the patients. We have calcium channel blockers in the form of nifedipine and diltiazem. This healing is good, but it takes 6 to 8 weeks for this treatment, and patient is having drowsiness, headache, and mood swings often. And these ointments, each ointment costs about 200 to 300 rupees for 1 week. Then one more is there, this botulinum injection, it is also a neurotransmitter. It is locally, it is given locally for the relaxation of the internal and anal sphincter. The relaxation is given for this to so that the fissure will heal till then. But there have been, it has been reported that there are allergic reactions, bladder, increased bladder residual volume is there, muscle weakness is there, postural hypertension, and injection site infections are there. And some transient flatus incontinence is more common. The recurrence of the healed fissure after 1 year is more than 50% in botulinum injection. Then we have dilators. Anal dilatation. Anal dilatation, it can be self-dilator, where the patient is trained for this dilatation. He can use this. This is readily available in the market. He can use this at home daily. And then we have this Lord's dilatation also, where we do usually four finger dilatation. But both this Lord's dilatation, we have to do it in the hospital setup for under spinal anesthesia or under general anesthesia. But their rate of incontinence has been also reported in this, but lower than the lateral internal sphincter, because during this dilatation, some lower fibers of the internal sphincters are tear out, so it may lead to incontinence of this. We have lateral internal sphincterotomy. It can be open, it can be closed technique, but both are very good. It is considered as the gold standard of the treatment for the fissure in NU. But for this, we have to, it can be done in local anesthesia or spinal also. But we have to take the patient to the OTA, trauma is there, and then this incontinence has been reported from 3.2 to 16, 3.3 to 16% also. We have advancement flap anoplasty, where we do plasty in the form of this. You can see here rectangular flap, or VY plasty is also done in these cases. But there is lower risk cases of incontinence are there, but there is necrosis, wound dehiscence, and infection chances are more there in such case. And we have to do it in spinal anesthesia. Fissurectomy and fissurotomy has been also reported with some fissurectomy incontinence and fissurotomy with incontinence, 2% incontinence, and fissurectomy 7% incontinence has been reported there. We have laser also, although it is very, this patient can resume his work just next day, but it is costly. There is incontinence, there is infection, and sometimes bleeding is also there. In Ayurveda system of medicine, what they do, they use Shar Sutra, particularly for the sentinel pylon chronic fissure, they use Shar Sutra also. And they use local medication in the form of enema, in the form of Shishvat, in the form of ointment. But all these are herbal or herbo-mineral combination. In Siddha system of medicine, they don't prefer surgeries. They give some internal medications, and these are herbal only. And external medication, they give ointment as fumigation on Shishvat. These are the herbal preparation, or mineral, or both herbo-mineral preparation. Then in homeopathy, there's a long list of medicines available. They also treat it only conservatively. So now where do we stand after discussing all these treatment options which are available right now in India particularly? What should we suggest a patient, and what is the better option for the patient? We have discussed this in surgical, in conventional, or in Ayurveda or Unani Ilaj. The first and foremost thing, and in every surgical case, there is the trauma. You have to take the patient inside OT. You have to inject some local anesthetics, or another spinal anesthesia. Then there are expenses for this procedure, but then there is hospital stay, and you will advise, surely you will advise the rest, although in laser surgery, no rest is required, but patient still will skip his office, skip his work for few days, and there are complications I have mentioned there. Then medical, I have mentioned the medical expenses, the appointments in the form, they have side effects, they have recurrence, they have, the treatment duration is long. And moreover, those are very expensive ointments which are available in the conventional medicine. In comparison to this, we have Ayush. In Ayush system, we have herbal, we have mineral, we have herbo-mineral combinations. So these herbal mineral or herbo-mineral, these are readily available. These can be prepared at home, and clinician can prepare, be it Ayurvedic, the Unani clinician, they can prepare it easily from at home. And we, during our studies, clinical trials, we have not seen any side effects of these preparations. And moreover, these are very economical. It will cost, surely it will cost 2 to 3 rupees per day for a patient, in comparison to this medical, like diltiazem, nifedipine, they cost 25-30 rupees per day. And these our preparation, these Ayush preparations are easily to prepare and readily available. So from this, what is the then effectiveness of the treatment? What you should suggest, and what should be the choice of the for the patient? So according to this discussion, according to my own view, you may differ it, but it's a suggestion. The first choice of the treatment for anal fissure should be herbal, mineral, or a combination of herbal, mineral, along with strict diet restrictions and sitz bath. This should be the first choice for the patient, whoever, whether in acute or chronic. But in case a patient is not responding, or a patient is not willing to go for this medication, or patient is not responding to your treatment beyond 4 weeks or 5 weeks, 6 weeks, 8 weeks. So you must put other treatment options before the patient. You must explain the benefits and advantages and the disadvantages of the treatment, all treatments available to the patient. Still, if the patient seeks your suggestion, what should I go now? Where should I go now? I have this herbal or mineral or herbal mineral medication. I have not been cured. So what should, if he seeks the suggestion? So in my view, then there should be the LIS in local anesthesia. This is lateral internal sphincterotomy in local anesthesia should be the treatment of choice after this, if the patient is not cured by these medicines. It can be easily done in this local anesthesia on daycare basis. The patient will be back by in the same day. Or if you will, a second option should be the Lord's dilatation or local lateral internal in this sphincterotomy under spinal anesthesia. This Lord's dilatation we have to do it under spinal anesthesia. So what now we will conclude it stop. So from all this discussion, we have seen that this condition can be prevented easily if the patient is aware of this condition. If he can avoid all this, alter this lifestyle, change this lifestyle modes, if he can be well hydrated, if he can use this moderate exercises, he has to use the meals properly. So it can be prevented, but it needs education and awareness among those who are at risk. And we can be a part of this, and but we cannot do it on ourselves. We can be only a part of this awareness and education. Then the condition is easy to treat. if the patient is coming to you, it is very easy to treat. You have to diagnose it, but the proper diagnosis is required. Proper diagnosis is a must, and early diagnosis is a must. For this diagnosis, our clinicians who are working in peripheries or primary centers, they must have some facilities, and they must be trained for this proctological examinations and preparation of these ointments. They can be prepared, trained for these various programs like CMEs, so that they can manage and these cases at their clinics, at their primary centers. Therefore, I anticipate that education and awareness will prevent this condition, and patients will seek the early expertise consultation if they will be aware about this. If these clinicians, these practitioners who are working in therapy, they will get enough this training through various programs. They can manage this condition efficiently at their primary. They can diagnose it properly, and they can then manage it there at their primary level. So this was all about my topic. I'm thankful to everyone for being with me, for patient hearing, and I would like to acknowledge my patients who have volunteered for the studies, my colleagues for the valuable discussions often we do have about this topic. Thank you very much. Thank you, organizers. Thank you, everyone.
Thank you, Dr. Firdaus Ahmed Nizar, for your nice presentation. Now, all the participants are requested to put your queries because our speaker is available for any query from participant side. Please put your questions. Any question is there? From participant side, please ask your question. No question, I think.
अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम।
जी सर, डॉक्टर मुस्तफा बात कर रहा हूँ सर, कर्नाटक से।
जी बताइए।
सर असल में ये जो साइनस का भी हमने सुना, जितने भी फीचर बोले सर, यूजुअली ये अकॉर्डिंग टू यूनानी कॉन्सेप्ट जो है सफरावी मिजाज और दमवी मिजाज में होने के चांसेस बहुत ज्यादा हैं क्या सर?
जी हाँ, बिल्कुल।
सफरावी मिजाज जी, तो और जो
सफरावी और सोदावी, सफरावी और सोदावी
सर। जी, इसमें कंपाउंड ड्रग्स कुछ असर कर सकते हैं सर? इनमें कंपाउंड ड्रग्स हमारे यूनानी में
कंपाउंड ड्रग्स बिल्कुल मैंने बता दिया आपको, फॉर्मुलेशंस में है, जो फॉर्मुलेशन कर सकते हैं, क्यों नहीं कर सकते हैं।
जी सर, अभी एक आपने मरहम बताया सर, उसके अंदर जो है मुर्दार सिंह, सुकैदा काशगरी और रोगन गुलाब,
हम इसको इस उसूल पे इलाज करते हैं कि ये जो है हमें ये हर मैंने बता दिया, हरारत और रिबूसत की वजह से ये मर्ज पैदा हो जाता है वहाँ पर, मुकामी तौर पर वहाँ हरारत पैदा हो जाती है, रिबूसत। तो हम जो है दवाई दे सकते हैं, इसमें ये दवाई, ये बारिद मिजाज की दवाई है, तो इनकी वजह से वहाँ मिजाज का जो है तादील हो जाएगा, मिजाज सही हो जाएगा, ये ठीक हो जाएगा।
सर इसी तरह मैंने चंद पेशेंट्स को देखा जिनका मिजाज बलगमी है, वो भी इस कंप्लेंट से आते हैं सर, तो उनमें कैसा है सर?
तो क्या आपने इलाज करके देखा उनका?
जी सर, उसमें जो है मैंने इतरफिल सनाई डाला था सर, हब्बे मुक्तिल डाल कर था। वो कभी बोलते हैं वो इस्तेमाल करने से कुछ फायदा होता, छोड़ने से जो है फिर वही कंप्लेंट होती है। और उनका जो मेन ऑक्यूपेशन है सर, वो सॉफ्टवेयर इंजीनियर है, कंटिन्यूसली 8 to 10 आवर्स बैठते हैं सर, तो मुझे उसका परहेज। जी
वही मैंने बता दिया कि ये जो मैं पहले शुरू में बता दिया कि लाइफस्टाइल डिसऑर्डर बन गया है अब, तो क्योंकि जो मल्टीनेशनल कंपनीज और जो हमारा ये वर्चुअल मोड, घर पे बैठना और ऑफिस पे कंटिन्यूसली 8-8 घंटा बैठना, और वर्क स्ट्रेस, वहाँ पर सीट नहीं छोड़ सकते हैं आप इन बिटवीन, तो ये इसका फैक्टर है। दे हैव टू अवॉइड, उनको बताना पड़ेगा आपको, इसलिए हम अवेयरनेस बता दिया कि अवेयरनेस की जरूरत है, so that they can alter their this work culture. We cannot we cannot advise every patient to change his profession, which is not possible. But कुछ modification कर सकते हैं वो, surely it will heal if they will modify their routine. वो असबाब सित्ता ज़रूरियात का मैंने जो जिक्र किया था वो इसी में आ रहा है, तो उनको इस चीज़ को मॉडिफाई करना पड़ेगा, तो वो हील हो सकता है। अदरवाइज अगर फैक्टर वही रहा, आप दवाई देते रहिए, वो हील होता रहेगा, बनता रहेगा, हील होता रहेगा, बनता रहेगा, तो दे हैव टू अवॉइड दिस।
Yes, sir. Jazakallah.
Thank you, Dr. Firdaus, sir. Any other question from participant side? Thank you very much. Thank you, Dr. Mustafa, also.
Thank you.
I would like to inform all the participants that today's program, today's webinar is the last one. Previously, we have completed 3 webinars successfully under the dynamic leadership of our HOD, Professor T.S. Alam sir. He has given moral support as well as he has provided well infrastructure support for the organization of these type of webinars. So I am very much thankful to our HOD, Professor T.S. Alam sir also. We have completed on 23rd of March this year, first webinar having 2 topics. First topic was laparoscopic procedure in surgery, presented by my teacher, Professor Iqbal Ali sir. Second topic was laparoscopic instrument used in general surgery. This presentation was done by very nice presentation, our HOD, Dr. Professor T.S. Alam sir. And second webinar was done on 23rd of April, having 2 topics, non-healing ulcer and its management. And second topic was hemorrhoids and its management. This second topic was presented by our colleague, Dr. Nazreen Fatima. And first topic, non-healing ulcer and its management, this was presented by our senior, Dr. Minhas sir from Hamdard. And third webinar was completed successfully on 4th of the June. 2 topics were covered. First one is the urolithiasis, which is covered by Dr. Manzoor Ahmed from Pune. And second topic was thyroidectomy, which is covered by me. Today is the 4th one and last webinar of this webinar series under the celebration of Azadi Ka Amrit Mahotsav. And 2 topics are covered nicely, very nicely, really. One is management by our teacher, Professor Tafsiri sir. And second one, Fisher in NO, treatment updates. Where do we stand? Very nicely presented. Where we stand in 2022. Very nicely presented by our colleague, Dr. Firdaus Sahab. So all the participants are requested to fill out the feedback form because e-certificate will be sent to all the participants who will fill out the feedback forms. Now, at the end of this program, I invite my colleague, Dr. Mehrdeen Fatima, a very enthusiastic lady surgeon and assistant professor of my department, Department of Ilmul Jarahat, NIUM Bangalore, for a vote of thanks to all the participants and all the available personalities of this webinar. Dr. Mehrdeen Fatima, please.
Thank you, Dr. Shakil Ansari. Assalamu alaikum to everyone. Am I audible?
Yes,
Yes,
you are
yes,
audible.
Honorable Director NIUM Bangalore, Professor Abdul Budur, sir. Respected HOD, Department of Ilmul Jarahat NIUM, Professor Sayyid Shah Alam, sir. Respected speakers, Professor Tafsir Ali, ex-chairman, Department of Jarahat, Ajmal Khan Tibbiya College, AMU Aligarh, and Dr. Firdaus Ahmad Najjar, Assistant Professor, Department of Ilmul Jarahat, NIUM Bangalore, and all the participants. I, Dr. Mehrdeen Fatima, Assistant Professor, Department of Ilmul Jarahat, NIUM Bangalore, take the opportunity to put my gratitude into words. I extend my gratitude to our Honorable Director, Professor Abdul Budur, sir, for giving the support and encouragement to organize this webinar. A special thanks to my respected teacher and today's speaker, Professor Tafsir Ali, ex-chairman, Department of Jarahat, Ajmal Khan Tibbiya College, AMU Aligarh, for accepting our invitation as a speaker despite of his busy schedule and enriching us with his profound knowledge on burn and its management, and especially Unani aspect for the post-burn wound care. I must thank to our colleague and speaker of today's webinar, Dr. Firdaus Ahmad Najjar, Assistant Professor, NIUM Bangalore, for sharing in-depth knowledge on fissure in NO, especially all the treatment modalities including Unani system of medicine, which is present till date. I extend my gratitude to our HOD, Department of Ilmul Jarahat, NIUM Bangalore, Professor Sayyid Shah Alam sir, for providing immense support to make this webinar successful. I must thank the organizing team for working hard from the past few days to make this event successful. I would like to thank to the IT team, NIUM Bangalore, for their unconditional and continuous support. I would like to thank all the participants for their presence and enthusiasm and for giving the valuable and encouraging comments during the webinar. Thank you everyone once again for making this event a great success. Assalamu alaikum.
Okay. So,
Shakil sir, over.
Thank you very much. Thank you very much. Now it is the end of this webinar, today's webinar. Now it is the closure time. Thank you very much to all the participants, especially our speaker also. Thank you very much.